therapy, the role of the medical nutrition therapy and the interventions are very, very important. So now we'll come up one by one. So also I'm giving the topic that nutrition intervention in diabetes, basically medical diabetes. So metabolic syndrome. Diabetes is not a disease. Diabetes is a metabolic syndrome. So diabetes can be controlled. Diabetes can be on remission. If it is remission, diabetes is there. But again, it's under the metabolic syndrome, and lot of factors are associated for the diabetes mellitus management. Number one is the abdominal obesity. So obesity is one of the key factors because we all know the adiponectin, we all know the leptin, and all know the visceral fat. That is very, very important part which is not controlled. The insulin resistance can occur. If insulin resistance can occur, so diabetes mellitus can happen. If there is other hormonal structure, hormonal metabolic dysfunctions can happen due to the adiposity, due to the leptin, due to the ghrelin and other hormones. So that's why obesity, especially the central obesity, is one of the major factors for having childhood diabetes mellitus. That's why we try to maintain the BMR, body mass index, and the BMR and also the central fat. This is number one. Elevated plasma triglyceride level. So triglyceride is a very important thing. So in triglyceride, simple lipid we know, if it is triglyceride is not controlled. If it is triglyceride is more than 250 or 200, so in that cases diabetes can happen. So we all know, the students are there, we know about the de novo synthesis pathway where we can see the fructose. If the fructose is not metabolized properly, if the fructose is not going to directly the ATP cycle to the energy pathway cycle or the proper, their cytochrome A or cytochrome B pathway for the electron transport system chain, these fructose will go to our acetyl coenzyme pathway, and that can increase the monoacetyl, diacetyl, triacetyl and triglyceride formation. So triglyceride de novo synthesis is very common. If it is not controlled, then diabetes can happen. Low plasma HDL cholesterol level. So cholesterol not always bad. Cholesterol is always very important sometimes in our body for bile function, also the hormonal mechanisms and everything. So not only cholesterol, not always bad. And whereas HDL cholesterol is a very, very important cholesterol that can give a very good factor in our body. So if it is low HDL cholesterol, so it definitely is a U-shape, is a deficiency of the U-shape of the cholesterol and the insulin sensitivity. If the insulin sensitivity is not there, insulin resistance is there, so it will be happen type 2 diabetes mellitus. Elevated blood pressure. Some people are only having the blood pressure medications. Maybe it is beta blocker, maybe it is alpha blocker, maybe it is calcium channel blocker, maybe ARB, maybe AC inhibitors, and all those medications. There are a problem with the RAS pathway. They can increase the RAS pathway, RAS activated pathway, and this elevated blood pressure can decrease the insulin formation, insulin sensitivity, and can lead to diabetes. So elevated blood pressure, if it is blood pressure is not controlled, then it will be again detrimental from the blood glucose. So there are genetic expression is there, mutations are there, but the lifestyle modification, lifestyle management are simultaneously important for diabetes management. So this is the one of the other key factors. And elevated fasting blood glucose. This fasting blood glucose is much more higher. Maybe postprandial is controlled, but the fasting blood glucose is higher. So in that cases, what will happen? It will be effective for the insulin secretion. Insulin resistance will occur, and also you know very well about the Dawn phenomenon and the Somuji effect. So these can happen if the fasting blood sugar is elevated. So these are all the factors, a big overview where diabetes can happen. Apart from these, diabetes, when diabetes comes, diabetes invites lot of other comorbidities, other targeted organs failure. So in that cases, hypertension is one of the things where heart is associated. So diabetes cardiomyopathy is very common, and also NAFLD, non-alcoholic fatty liver disease. NAFLD is sometimes alcoholic fatty liver disease, sometimes compensated or decompensated fatty liver disease. Hepatogenous diabetes are very common if diabetes is not controlled. And nowadays is a modern science. There is some paradigm HF about the MAFLD, that is the metabolic induced diabetes mellitus. So MAFLD is also there simultaneously with the NAFLD. And also the cardiovascular events, what I have said, that diabetes sometimes if it is not controlled, it can do some cardiomyopathy, MI, ischemia, called chronic heart failure, and lot of other cardiometabolic issues. So these are the disease associated with the metabolic syndrome with the diabetes. Now, why medical nutrition therapy in India? How medical nutrition therapy come to this picture? There are a lot of physicians, colleagues sitting in front of me. They know that also Dr. Aditya has come. So these are very, very important. Why medical nutrition therapy in India are so important? Because drugs are there. Once you go to a clinician, endocrinologist or diabetologist or gynecologist or physician or diabetologist, they might have give you metformin, biguanide drug. They might have give you insulin secretagogues. They might have give you SGLT2 receptors. They might have give you some DP4 inhibitors or any alpha glucosidase inhibitors. A lot of drugs are there, or insulin. Some people are there very much phobic, and they are very needle phobic. They are very reluctant for take the insulin, but they are having the oral hypoglycemic drug. But oral hypoglycemic drugs are not only solution for controlling diabetes, because oral hypoglycemic drugs are depend on your food. If we see or if we get to know about the alpha glucosidase inhibitors mechanism of action like voglibose, acarbose, we can see they are trying to control the glucose. The simple glucose they are not intended to have. They are trying to make the complex carbohydrate. But if we have in our diet too much of rasagullas, too much of sucrose, too much of glucose, intaking lot of fast food, junk food and deep fried food, free radical food, that will give a detrimental part of our diabetes habit. So in that cases, medical nutrition therapy are simultaneously very pragmatic, and this is a very holistic approaches for controlling diabetes mellitus. Now, what I've said, there's MNT, we used to say it in abbreviated in MNC. The MNT, we know very well because the auditors in their cases are MNT chapters on different topics. Diabetes, gynecology, pediatrology, everything. So MNT is a very important thing, and that management. Because our diet should be tailor made, our diet should be customized, and our diet should be biochemistry wise, and diet should be food choices. Because nowadays some people are vegan, some people are non-vegetarian, some people are over-vegetarian, some people are lacto-vegetarian, and despite of the classes, like some people are privileged class or underprivileged, so what type of food they're used to take. So you have to talk to the patient. So after doing the diet calculation, what I see instead of the diet chart, it should be a diet prescription. So after having the diet prescription, you have to counsel to the patient, because any diabetic patient, they are very what I will say very negative thoughts. What will happen to me? Maybe because nowadays internet is there, they can see any kind of things in any time at any given point of time. So they are very frightened. So you have to do the proper counseling to the patient. So your diabetes should be managed. If you do proper medication, proper dietary management, if you take insulin, so proper insulin regime, exercises, and also the discipline. So it should be all over behavioral changes, a tailor-made diet prescription, and also counseling by a qualified clinical dietitian and a certified diabetes educator to a patient. Lifestyle parameter. Dr. Mitro is medical super in my hospital, Samaritan Medical Surgical Critical Care. He knows that in our hospital, after admitting the patient, we do the in-body composition. Basically, any diabetic patient, diabetes basically has starvation and is plenty. So you have lot of food, but you can't utilize this kind of food. So sarcopenia is one of the major phenomena can happen. So not only your height, weight, BMI is not the key. In our hospital, in Samaritan, what we do the proper in-body composition, where we can get to know the height, weight, BMI, BMR, visceral fat percentage, protein percentage, fat percentage, muscle percentage, in the minerals percentage in detail. If there is any extracellular fluid or intracellular fluid is there, we can try to kind of a proper calculation. So this one simultaneously from the anthropometric measurements will get to know. Setting goals, particularly achievable, acceptable to the patient. You can do a diet to a patient is too costly, like spaghetti, like lot of oats, lot of supermarket food. Patient sometimes is not able to purchase this kind of very high cost food. So high cost diet and high cost food, that doesn't mean that too much of the calorie is there. So in that cases, what you will need to know and kind of what the vitamin B12 sources. So what are the other references for that? Maybe calcium, maybe protein for that. So we have to talk to the patient, then only you will get to know what are the other, whatever is the alternatives are there. Evaluation to assess if the goals have been achieved and make necessary changes. So you have to talk to the patient. Your diet means it's not like no to all the food. It's like of your slight behavioral changes, that what you are having and what you will have to a proper manner. So assessment before advising diet, where I will say several times, make people with the diabetes to understand the alterations in their dietary habits, and also the cooking mechanism should be there. So what we will say, you can do the boiling, broiling, you can do the shallow fry, but not the deep fry to a particular food. If we do the deep fry, then the free radical can come. If the free radical come, reactive oxygen species can come, and they are very detrimental for all the syndrome X and the non-communicable diseases like diabetes and also cardiovascular problem, also any kind of palliative problem, and also other like liver problem, any kind of hepatic hepatitis. If Queen is there, that lot of GDM patients also. If the GDM patient, they can modulate the diet properly, so they can't control with their in their gestational life, that can for their baby it will be lot more detrimental effect for that. So in that cases, for the GDM patients, you have to maintain the SOP for maintaining the proper protocol of this diet. So guideline recommendation from the American Diabetic Association's recommendations for the MNT, where they say the preventing diabetes, but the primary preventions of the diabetes, where we can say sometime remission of the diabetes mellitus, where American Diabetes Association says that the 6.5% of the HbA1c below that, or the diabetes level 125 to 126 mg/dl, below that you can do the remission. How do you do the remission? With the proper medical nutrition guideline and medication nutrition therapy. After that, once you go to the physician, any kind of endocrinologist, they can give you a medicine prescription. So before that, you have hand that you can reverse the diabetes. So prevention diabetes, moderate weight loss by about 7%, low GI, low glycemic index, low glycemic load food that you can have, regular physical activity, 150 minutes per week that you can do, that daily 20-25 minutes walking you can do, and the fiber intake 14 gram per 1000 kilocalorie. So the fiber intake should be, according to our RDA guidelines, that 40 grams of dietary fiber, soluble and insoluble dietary fiber, both you can have on daily basis. What about the controlling diabetes? The secondary prevention, reduce intake of the calories, salt, trans fat, sucrose, cholesterol and sodium. Because in our patient, once we do the counseling to the patient, maybe there restriction of the table salt, like sodium chloride, but sometimes they are not restriction for having the outside canned food, junk food, where contain too much of sodium. So too much of sodium again will give you the detrimental effect. And also the trans fat. Trans fat should be negligible. You shouldn't have much more of trans fat. What the trans fat happen? Because intensive students, you know very well that if we do any kind of oil, liquid temperature to the hydrogenations process to a solid temperature, like samosa, namkeens, any kind of margarine, any kind of cookies, that having a lot of trans fat. So trans fat shouldn't be there. Regular protein consumption, that should be 15-20% from the calories. Variety of fiber, where lot of fiber are available in the market, lot of pharmaceuticals and nutraceuticals are there, where you can get to know the roles of the soluble dietary fiber to attenuate cholesterol and diabetes, and also where resistant maltodextrin or lente carbohydrates or resistant starch also can do a proper mechanism of your fiber management. Because you know very well that resistant maltodextrin can't walk in your small intestine. They directly goes to your large intestine. From the large intestine, they are taking the large colonic epithelium and they are increased short-chain fatty acid like butyrate, and they are actually working as a prebiotic. So prebiotic and the probiotic symbiotics was a tremendous effects for the diabetes management. Increased physical activity. So not only diet but also 20% physical activity according to American Diabetes Association's guideline that we have to adhere and follow. Manage complications of diabetes by tertiary prevention. Target A1C as close to normal as possible. Dietary sodium less than 2300 mg per day. Sometimes a heart failure patient, we try to restrict the sodium intake. For the heart failure patient, if you're having lot of sodium, that could be detrimental for the edema and all the things can happen. So sodium intake should be with the proper manner, and if you are having the oral hypotensive drug like AC inhibitors, ARB, beta blocker, calcium channel blocker, there should be the regular salt intake, not the table salt. So if it is hyponatremia, that will be different cases. I'm talking about in general. Multidisciplinary approach to manage microvascular complication, diabetes retinopathy, diabetes nephropathy. So this can happen if it is not diabetes proper, because diabetes CKD, you can know very well if it is diabetes not properly occurred, high urea, high creatinine, renal shutdown can happen immediately. Research Society for Diabetes in India, RSSDI, but RSSDI, and I am the member of the Associations of the Diabetes Association of India, they have some different protocol. That protocol says that carbohydrate intake should be 45 to 65% from the total calories, predominantly low GI, that you know very well, low GI and low GL. Maybe watermelon have higher GI, but the GL, glycemic load is low. Glycemic load is 6. So low GI fruits and low GL food should be recommended. Increase soluble and insoluble fiber intake, that should be there. Substitute polished white rice with millets and the brown rice. Look, brown rice is not always recommended, but millets, you know, where we sometimes say about the ragi, jowar, bajra, sorghum, foxtail and all those things. So we can give to the patient, but instead of having our main objective to discuss with the patient, you try to refrain from the refined carbohydrate, and you can have the high, what I can say, fiber and whole grain cereal of carbohydrate. So carbohydrate should be the whole grain cereal instead of having the refined carbohydrate. This is very important. For the protein intake, at least 15% from the total calories you can get the protein, and addition of the insulinomic cereal pulse mixture. So you all know very well where we can have sometimes try to prescribe khichdi. Why khichdi? Because we can get both the amino acid. Like we can get the methionine and we can get the lysine. So cereals will be a very good combination for getting all the essential amino acids that we should depend on the outer dietary sources. So that's why you have to talk to the patient যে আপনি খিচুড়ি খেতে পারেন. So they will get to know about rice and pulses mixture. Sometimes you can get the importance of the fish also. The fish contains lysine, important amino acid that will get from the khichdi. Fat intake restricted into the saturated fat less than 7%. The saturated fat like ghee, like vanaspati, like butter, like cheese, maybe those have a minimal amount of the MCT, medium chain triglyceride, but if you talk to the patient, patient will have a tendency to have lot more of these, lot more of butters. That will give it again detrimental effect to the diabetes cells. So in that cases, you should restrict the saturated fat less than 7%. Try to include the MUFA, monounsaturated fatty acid like grapeseed oil or mustard oil, Tetra Pak mustard oil, 10 to 15% from your diet, and you can go for less than 10% PUFA, polyunsaturated fatty acid. You know very well omega-3 fatty acid. Omega-3 fatty acid are very great examples of the PUFA that you have to include in your diet, but the SAFA saturated can be there, but less than 7%, but minimal negligible percentage transfer should be there. Look, any kind of food somehow we can segregate ki transfer ekdamই চলবে না, it's not like of that, but transfer may be there, but not transfer dominating food. minimal trans fat, what I've said you before, and dietary cholesterol. Cholesterol is not our enemy. What I've said you before, cholesterol is also happening our bile cell formations, our hormonal mechanisms, and all the functions are there. But we shouldn't intake of too much of cholesterol-rich food from the outside. Maybe one egg yolk, hence egg like 255 mg of cholesterol that you can take, or dark steak 355 mg of cholesterol that you can take. But if you take more than 2-3 eggs and 2-3 egg yolk, indirectly your beta oxidation, fatty acid oxidation, omega oxidations can occur. So if fat is increased, I've said you before, if diabetes can happen at any time. So cholesterol not directly hampered to your health, but indirectly it is fat. In that cases, try to as less as possible cholesterol from the outer sources you can take. Other recommendation, reduce intake of the refined sugar. You shouldn't go for refined sugar. Maybe refined sugar, sucrose is there, that is glucose and fructose, but not always glucose and fructose is not recommended. I'm not talking about the critical care nutrition, that DNAs and other things are different, but I'm talking about the OPD patient. You shouldn't prescribe ki apni chini khan. Sucrose, mishti and glucose is not recommended. Sometimes fructose will, I have said you that fructose are different pathway. If fructose goes to your beta oxidation, omega oxidation pathway, it can directly go to your de novo synthesis, increase your triglyceride level. So you have to walk and you have to talk to your patient diligently and pragmatically. Other recommendation what I've said, and also dietary salt should be less than 5 grams per day. I'm talking about the artificial sweeteners. You can take stevia, you can prescribe sucralose. That should be generalized, recognized as safe, for the recommendation is there. Follow the FDA recommendation, but not too much of that is what I will say, that sucralose and stevia is there, but aspartame. Aspartame is the boiling temperature or heating temperature is there, they can increase your phenylketonuria problem. So in that cases, again artificial sweetener, it should be, there are a lot of debates are there, but try to avoid it. Some people are not avoiding, they are restricting their calorie and nutrients, so you can increase artificial but little bit of amount also. But strictly avoid alcohol consumption and tobacco. Maybe our textbook says about these kind of things, alcohol present of this amount of calorie, but if you say to green signal to a patient, you can policing to the patient will have much more amount of the alcohol. So alcohol, any form of tobacco should be seized for the diabetes mellitus. A plant having lot of good antioxidant, good flavonoids and all those things. We taught about lycopene, we taught about isoflavone, we taught about genistein, we taught about epicatechin gallate, we taught about asparagine, naringenin, all the antioxidants you will get from the plant source. So the plant-based supplement in diabetes will be the major key factors for managing diabetes. So the research says that changes in metabolic risk factors, body weight, fat mass, hormonal parameters after 6 weeks of the lifestyle intervention that you can do after regimen of the low calorie diet. Now I'll go to this picture. This graph you can see the prevalence of the metabolic syndrome was reduced in 12% in the MRDG, like who are having the meal replacement supplement, but the control group of the LCD, only low calorie diet, after 6 weeks there is no change. So we can for your glucose management, your insulin secretion, and reduce your glucagon secretion. So in that cases, you have to always go for a high protein and high fiber. Always I am saying, maybe insoluble dietary fiber are good for your constipation, diverticulosis, all the problem, but soluble dietary fiber will give you a health effects for attenuates your cholesterol and your blood sugar maintenance and your insulin secretion, and basically they are very good dietary, soluble dietary fiber. So soluble dietary fiber in the high protein supplement will give a very good index. Participants underwent this kind of survey was there, but we can see the plant-based high fiber